So our next speaker is Dr. Jayashree. And Dr. Jayashree, can you share your slides?
Yes, ma'am.
She is professor and head of the Department of Community Medicine at BGS Global. More will come with her slides. I'm going to introduce her. I hope you have made your slide, your profile.
1 second, ma'am. Yeah. Is it visible, ma'am?
No, not yet. We can't see you. Now it's clear. Yeah.
Now it's
Put
clear,
it in
ma'am.
the slide mode. Yeah. A full
Yeah,
slideshow. Yeah.
I'll do that. Yeah.
Yeah. Go to your profile.
Yeah.
Intro.
Okay.
Yeah. Actually,
Yes.
okay. So Dr. Jayashree is a professor head Department of Community Medicine at BGS Global Institute of Medical Sciences. She's got 26 years of teaching experience. She is member secretary of IEC, IEC at BGS Global, and she's chairperson of IEC at Kaveri Hospitals, curriculum committee member. And I have known Dr. Jayashree from 2006. 2004, I suppose. Yeah, more than 20 years. We were colleagues at Vaidehi Institute of Medical Sciences. Right from her early career, no, she has been very actively involved and good speaker. And her content delivery was something which I liked, as I have liked with Dr. Praveen and Dr. Shashidhar and all the speakers for this workshop. She has also been always my, good choice for me because she delivers contents very effectively. And recently we had a session at Atal Bihari Medical College also, and very successfully. Students liked her this one talk, and now she will be speaking on study variables. Over to you, Dr. Jayashree, and thanks for accepting this invitation. Yeah,
Thank
please
you,
go.
ma'am. Thank you for your kind words. I'm humbled to be present here, especially with such enthusiastic students and also the elite speakers like you, Shashi sir, and also Dr. Praveen. It's a pleasure to be talking. I'm quite intimidated also.
No, it's not to be.
Coming back, I request all the PGs to kindly let us try to make it interactive. I shall take off from where Dr. Praveen Kulkarni started yesterday and he concluded. So, yeah. So, before we actually go ahead with study variables, there is a reason why we do research. Can someone tell me, unmute yourself and tell what is the main objective whenever we are doing any research? What is the main objective besides the fact that it's a mandatory completion of your for your postgraduate course and all that? I saw Apurva. I think I saw Nisarga also. I remember a couple of names.
Yes, you can open up. Don't worry. Even if your answers are whatever be the answers, please open up.
I usually give the silliest answer, so it's okay.
Please open up anything, whatever you answer. Yes, Preeta. Yes, Preeta.
Ma'am, research, the term itself says that researching something on particular topic, so that if we restudy as the generation goes on, so there might be some new ideas or we can add up the new technologies and everything. What better can be done is the purpose, I felt.
Lovely. Thank you, Preeta. Thank you for that very good insight. If you can see these pictures and make out something. See, whenever we are doing research, there are two things which we are looking at. One is, yes, there is exposure, and we are looking for outcome, isn't it? So we are trying to say there is something which causes something else. So there is always an input which is leading to a output. So we are trying to correlate between these two things, and we are trying to see if there is any change in the input, is it going to reflect in the outcome or the output. So, in yesterday's talk by Dr. Praveen, we were talking about lung cancer risk factors, isn't it? And what he noticed in the storyline, which was beautifully brought out, was he said smoking was associated with risk of lung cancer. We started with one case where we saw he was a smoker, then 5 cases where most of them were smokers. Then out of 50 cases, we saw that 70% of them were smokers. Now, then we said that smoking is causing lung cancer. But then, so there are 2 variables here. There are 2 factors, smoking as exposure and lung cancer as a outcome. But if you noticed, when he presented 50 cases, he also presented couple of other factors, like what was the age group, were they alcoholic, were they exposed to any other risk factor like alcohol, poor air quality, that is environmental factor, the address and all that. So what are all these called as? These factors, what we study in association between, one is exposure, second is outcome, and there are so many other things which we study are called as variables, study variables. So what is a variable? It is a characteristic or attribute or a quantity that can change or vary among study participants. That means there are individuals, and within the given individual, that characteristic might change. He might be a smoker now, he might stop smoking. There might be cessation of smoking, or there might be one smoker and one non-smoker. So it is a characteristic or attribute that changes or varies among study participants. So essentially, what are the characteristics? One is variability, that is among study subjects or over time it is changing. And second thing, what you can see is it is a measurable quantity. Say for example, smoking, do we measure, isn't it? Either we call him a smoker or a non-smoker, or else we say one person smoking from past 5 years, or else we talk about an individual smoking 5 to 10 cigarettes per day or 10 to 20 cigarettes per day. So we are able to precisely measure that exposure. That exposure or the outcome is measurable either as present or absent or as a quantity. Then it is also contextual. Say for example, again, smoking and lung cancer. Smoking is a independent variable. That means we are talking about smoking leading to lung cancer. Lung cancer is dependent on smoking, which is an independent variable. So essentially we saw what is a study variable, that is a characteristic among study participants, what we are going to study. The objective was to compare the exposure and outcome, isn't it? So in order to find out the relationship between exposure and outcome, there are certain variables which we measure. Those variables are characteristics which change over a period of time. They can be measured and they are contextual. I want to explain a little bit about contextual. Say for example, not one variable can be independent in one context and it becomes dependent in another context. Say for example, when we talk about physical inactivity and obesity. Say obesity is a dependent variable with respect to physical inactivity, which is an independent variable. But if we are talking about ischemic heart disease, obesity becomes independent variable and ischemic heart disease becomes dependent variable. We say obesity leading to ischemic heart disease. So we have two components. One is dependent variable and another is independent variable, the cause leading to effect. So here in this graph, can someone tell me what is independent and dependent variable? So independent, as the age increases, the height increases to certain age, then it becomes a plateau, isn't it? So height is a dependent variable with respect to age. So exposure is independent variable, outcome is dependent variable. Then why is it that Dr. Kulkarni was talking about taking other factors like sedentary habits or alcohol or passive smoking as other or age as such as other variables? So we want to prove beyond doubt that it is the exposure which is causing outcome and not other factors. Those factors are called as potential confounders or confounding factor. Say, for example, in yesterday's case, we had 50 cases of lung cancer which sir took from a cancer hospital, isn't it? But what if all those 50 people were above the age of 70? Is it because people above the age of 70 are at greater risk of developing lung cancer? It's a hypothetical question. No? I'm not talking about scientific evidence here. What I'm trying to say is we want to prove beyond doubt that it is not about age, it is about the smoking. It is about smoking which is causing lung cancer, not about age. What if this cancer hospital was situated in industrial area where there is lot of exposure to silica? Can that cause silicosis and then probably cancer or asbestosis or any other condition which can lead to lung cancer? Are we ruling out those factors? So always when we are doing a study, we look for variables of exposure, outcome, and potential confounders. So now, so far, I hope you have understood what we mean by variable, something, a characteristic which differs in an individual or between or among individuals. And these variables are independent or exposure variables, dependent or outcome variables, and then we have potential confounders. Okay, yeah. Now, if we go to this example, what we have been following right from day one, nephropathy in adult patients with uncontrolled type 2 diabetes mellitus. Can someone tell me what is independent variable here? Can someone unmute and tell me what is independent variable we are looking at? Yes? I can't hear. Sorry.
Yes, you have to open up. Anyone?
So exposure or independent variable here we are talking about is uncontrolled type 2 diabetes mellitus, isn't it? For ease, I have just written as diabetes. It is uncontrolled diabetes mellitus. What is the outcome variable we are looking at? Nephropathy. Right? So we have diabetes mellitus, nephropathy. And then what are the confounders? There are numerous confounders. There is age, gender, hypertension, smoking. All these are hypertension and smoking. They themselves can cause probably nephropathy. There are so many other conditions which can cause nephropathy, isn't it? So we have to remove the effect of, we have to remove the effect of these confounders to say that it is diabetes, uncontrolled type 2 diabetes, which is causing nephropathy. If you have to remove the effect of these things, you have to collect data regarding these things. Okay. So now, if you want to measure diabetes, how do we measure diabetes? Yes? How do we measure diabetes? Please. Clinical PGs?
Measuring blood sugar levels, fasting.
Blood sugar levels. Like what time of the day?
Fasting,
Can you be a little more
fasting.
specific? Yes?
Fasting blood sugar.
Fasting blood
PPBS.
sugar. What are the other ways you can measure diabetes?
Postprandial blood
HbA1c.
sugar.
Very good. Anything else? Fasting, postprandial, then
HbA1c.
HbA1c. Fantastic. Anything else? Yes. Fasting, postprandial blood sugar, HbA1c. Are you understanding the difference here? So it is diabetes what you are measuring. That diabetes can be measured by various ways. So your variable is diabetes. But what is data? Data is what is reflecting your variable. The data what you collect can be various things with respect to one variable. See, now for diabetes only you told FBS, PPBS, HbA1c. We will start from beginning. We can go as primitive as history of polyuria, polydipsia, and this thing. Okay, polyphagia. That also tells about diabetes. Then you have a previously diagnosed diabetic patient who is not taking treatment properly. That also could mean uncontrolled diabetes. I hope you're understanding. What I'm trying to drive here is, for the given objective, do not get deterred because I don't have money to probably do HbA1c. I don't have money to do probably albumin creatinine ratio or whatever. There are various ways in which you can select variables and then do a study. The data what you collect depends on number one, feasibility, number two, appropriateness, number three, it will tell the strength of association. So if you want to just say there might be an association, you can go very poor data, or you can be very specific with your data collection and get very strong association. So say for example, someone takes this uncontrolled diabetes mellitus as your study objective leading to nephropathy. You decide whether you want to take FBS, PPBS, or HbA1c. Furthermore, you need to be very specific with your data variable. What is it? Are you going to take single time FBS? Because you have to make a definition of uncontrolled diabetes mellitus. This is what we ask in methodology, certain definitions. Your definition of uncontrolled diabetes mellitus may differ from mine, or you could use standard WHO definition or any other definition. Do we have a definition in clinical medicine with respect to uncontrolled diabetes mellitus? Yes? HbA1c of more than 7, 8, 9, 10, anything? Yes?
6.5%.
HbA1c more than 6.5? For how long? How many settings? How many readings? Suppose my HbA1c was 5.5 all through in 10 years. Just last 3 months, I did binge eating of sweets and my HbA1c is 6.5. Do you call it uncontrolled diabetes mellitus? Yes. That is your definition. That is the beauty of this study. So you should be able to define very precisely who are your study population and who is not. That is enough. You must be very clear when a patient walks in, is there in your inclusion criteria or no? Is he exposed or not exposed? You make a decision. Yes, my definition is one single reading of HbA1c more than 6.5, I will consider him as uncontrolled diabetes mellitus. Again, here you will mention about duration. Are you going to take freshly diagnosed uncontrolled diabetes mellitus, or are you going to take long duration? That is also variable, isn't it? So whenever you are making an inference, you will have to specify very clearly. Diabetic patients of more than 5 years who are uncontrolled from past 1 year or a single reading of uncontrolled diabetes have 10 times greater risk of developing nephropathy as compared to those who are less than 5 years and control or something like that. So you have to be very clear with regard to your inclusion criteria. That is, you define your variable. So variables again based on your feasibility. Now again, you can just say uncontrolled diabetes. So when you're putting your data onto your Excel sheet, how will you put your data? You can just say yes, no. You have made a definition. If BS of more than 130 or 150 or 120, PPBS of more than 200 or HbA1c of more than 6.5. When you are entering the data, you will just write more than 6.5, less than 6.5 and just write yes, no. Or else you want to do further within the group analysis. You want to say, depending on increase in uncontrolled diabetes mellitus, increase in the HbA1c level, the chances of nephropathy increases. Then instead of yes and no, what you will do, you will give actual values. You will give HbA1c of 6.5, 6.6, 7.2, 7.8, 7.10. Then you can either categorize or make it continuous variable and then say what is the proportion of people who are developing nephropathy. Is there increase in chances of nephropathy with increase in HbA1c? So when you are collecting data, the study variable is very important in practical aspect. When you are collecting data, be very clear whether you want to make a yes, no of uncontrolled diabetes or you want to actually give values. See, all these have to be defined beforehand, even before you start the study. So what was the outcome variable? Nephropathy. Similar to diabetes. So either you can say nephropathy present, absent. So what are the tests to say the person has nephropathy? Physicians, medicine, general medicine PGs, do we have?
Yes, they are there. General
Yeah,
medicine.
I am a
PGs.
public health person. For me, nephropathy means urea creatinine high. That's all. I don't know any other
Everybody
test.
should know. Why only medicine? Everybody should know. General other.
So from
Make an
public health point of view,
Now
I
we have
usually
given in the research questions also. Please open
Yeah.
up.
So albumin, what is the ratio ma'am was talking about?
ACR.
ACR ratio, isn't it? So you can either give the ratio or you can just say present or absent nephropathy. See, all these have to be defined even before you start the study. Again, smoking. Smoking, it can just be yes or no, or you can grade the smoking. You can also talk about how many cigarettes per day or how many years of smoking, since how many years they have been smoking. All these things will strengthen your study, because if you're talking about chronic smoker, if you see that yes, it could be because of diabetes, but then we are seeing that smoking is a confounder. Among those who have nephropathy, even we are seeing that they are chronic smokers also. So you have to remove the effect of smoking. For that reason, you have to take history of smoking. So that means a person who is doing research, a researcher is one who has the scientific knowledge of all these confounders and tries to add as many variables as possible which act as confounders so that he can remove the effect of confounders. Again, age, can we do yes, no? We cannot do yes, no, isn't it? We have to specify age in years. So not all questions we can have yes, no. We'll have to specify age in years. Similarly, gender. We cannot say yes, no. We can pick one of the genders when we talk about gender. So we saw that when we are talking about variables, there are different types of variables. There are certain variables for which we can just write yes, no, where there are certain variables where we have to specify the numbers which is continuous. There are certain variables for which we have to pick among the options what we have. So coming to theoretical aspects, variables can be divided into qualitative and quantitative. So qualitative, that is, there is quantity, there is nominal and ordinal. So that means name, whether it is male, female, yes, no. So they are qualitative. There is no quantity. You're not quantifying it, whether it is present or absent, either male, female, or other gender. So there is no continuity also. There is only compartmentalization as this quality they have. Just naming them. Color exposure. So red, blue, and green color. So similarly, just nominal. What is ordinal? So there is a hierarchy. There is a continuity. When we say ordinal, we say, especially if we have anesthesiology or surgical PGs, usually you do pain. You say mild, moderate, severe pain. We have community medicine PGs, you usually take socioeconomic status, isn't it? Lower class, middle class, upper class. There is an order. There is an order from lower to higher. There is an order. But again, here you are compartmentalizing, isn't it? There is order. There is no continuous numbers given here. It is again yes, no type, but with an order. Mild, moderate, severe pain. But when we come to quantitative variable, we talk in terms of discrete or continuous variable. I will come to continuous variable. So the most common continuous variable what we see here is years. So isn't it? So we talk about years. So number of years. What is the height? What is the weight? There is no break in height, weight and all, isn't it? So it is continuous. Sometimes we have discrete variables also where there is no continuity, but there is value which is discrete. We will see, go ahead and see. From you only we will get examples of continuous and discrete variable. So there was one more study which madam had given on the day one is to compare the duration of post-operative analgesia provided by intrathecal dexmedetomidine versus fentanyl, intrathecal fentanyl as adjuvant to lidocaine. Now this is the exercise in between. I want you people to take around 20 seconds and tell me what are the exposure variables, how will you measure, what are the outcome variables, how will you measure, and what could be the, generally we don't use confounders in clinical trial, we do, they get matched, but still what are the confounders which you have to measure. So I request the postgraduates to tell me what are the exposure variables you are looking at. You can just write down what are the exposure variables. I want other participants also to kindly actively participate. Anish,
Yes,
Deepa,
better to call them.
Likhit, Dhanlakshmi, Sagarika, Namrata, Soni.
Exposure variables are
Yes, very good.
intrathecal dexmedetomidine
Yes.
and intrathecal fentanyl.
So that is the variable. So what is the data you're taking?
Data.
5 micrograms. So you also have to
Yes,
specify,
5 microgram.
quantify. Yes, yes.
Fentanyl 25 microgram.
Yeah. Intrathecal
Intrathecal
fentanyl. Yeah.
fentanyl. Yes.
Yeah.
And outcome variable is duration of post-operative analgesia.
How do you measure duration? What is the data you'll obtain?
Time.
Are you understanding? So you have taken drugs. Yes, that is the exposure variable. The outcome variable, how will you measure analgesia?
Pain score.
Anesthesia and undergoing spinal anesthesia for lower extremity or abdominal surgeries. How long? Is it analgesia or anesthesia? That's why I put pain score deliberately.
Analgesia.
How do we measure?
By pain score.
Pain score, yes.
Yes.
But what we are looking at here is, what is to compare the duration of post-operative. How will you identify the duration? Yes, pain score. How will you identify? What are the variables? Pain score is one of the variables, but how often will you measure? So this is a common problem what I face when I in the scientific committee, when my students are presenting, they just mention about Spain score, but then you want to look at duration, isn't it? Continuously will you go on asking pain score, or do you have a device which tells what is the pain score? Do you have AI enabled devices which look at the patient? Do you have cameras which look at the patient and identify the pain? So this is exactly what data you need to collect, and you have to be very precise. So this is what is the difference between a patient care. So in patient care, what do? You give the injection, you wait till the patient calls out and says, doctor, pain aagta hai, bunny, you give something. So that is when you go give medication. But whereas when you're doing research, you want to see for how long these two different drugs are having a pain relief period. So for that, you make a decision. So again, it is left to the clinician. You want to be very precise. The best way is to have AI enabled scoring system wherein, or you tell the patient that whenever you have pain of 0.2% or on a 0 to 10 scale, if you have pain of 1 to 3, you immediately press this button once. And if you feel that there is your pain score is 7 to 10, you press this button thrice. Something like that you can say. And then that will get reflected to you. There is one more method. You will mention that once in every 5 minutes or once in every 10 minutes, I will go on asking for the pain score. So you are getting pain score there, isn't it? You are getting in an ordinal scale. One more method is pain appears, disappears. What time? Nominal. You are just yes, no types. Yes, no at 5 minutes. Yes, no at 10 minutes. Yes, no at 20 minutes. Yes, no at 30 minutes. It will just say, if they go on saying no, no, no for 30 minutes with drug 1, and they say yes at 40 minutes as compared to yes at 20 minutes for the drug 2, you're trying to say drug 1 is better than drug 2 because the analgesia is for 40 minutes as compared to only 20 minutes in drug 2. So there are various ways of data collection. Please be very clear with your variable. What happens is most of the students come back at the end of the study with different varied data. We won't know. For some people, you have taken different timings. For some people, you have taken score. For some people, you have taken yes, no. That is not the way. You must have clarity. You are the scientific expert. You decide on how you want to collect the data and stick to that method of collection of data. Suppose you want to use this picture method as an indicator, as a tool for your data collection. You have to use the same similar picture for all the patients, or you leave it to their imagination and tell score between 0 to 10. You tell whether it is 10 or 0 or 4, wherever you put. You can use the same tool. You have to use the same tool. Of course, there are confounders. You will take other factors like age, pain tolerance. So there is pain tolerance also. Some people will not feel pain even if it is very severely painful. They'll give score of 1 to 3. But some people are so sensitive, they might give score of 7 to 10. So again, these are all factors which will be taken care of when you randomize. That is the beauty of randomization. We believe that equally those kind of people will be divided in both the groups. So, ma'am, do we have time for another exercise?
Yes, because
Because
next
this is a
session
very
we have
short
postponed.
topic. I want them to come up with their study and talk about the variables.
Yeah.
So there was one more study I remember, ma'am, which you had given as example.
Yes. Yeah, you can go ahead because third session we have postponed to tomorrow.
Oh,
Yeah.
I see. Okay.
So that they get a clear idea. We don't want to hurry.
Okay, fine, ma'am. Okay, fine, ma'am. Can I extempo ask students to come up if they have
Yes,
come up
yes.
with a topic?
I had given them an assignment. You
Yeah.
can ask them whether they have already they're
If
ready
you
with
have
that.
already thought of your dissertation topic, if someone can come up with your dissertation topic, then we can be, because I am not going into too much details of types of variables and all, ma'am.
Yeah, not
Because
required.
the
Yeah,
idea is for them to collect
correct.
data
Correct.
correctly. They have
Correct.
to be very clear with what is the variable
That's what.
and what is the precise data for that given
Correct.
variable.
Correct. That
And
yes.
most important is feasible, especially
Yeah.
when we are talking about dissertation, it is
Yeah.
feasible. As a
Yeah.
researcher, it has to be accurate.
Yeah. Other two examples also you can discuss, Jayashree.
Yeah, yes, ma'am. Yes, ma'am. If
And then,
if-
or either way, I leave it to you. Yeah.
yeah. I'll just give them half
Sure.
a minute time for them to
Sure,
come up
sure,
with their
sure,
topic,
sure,
and
sure,
then we
please.
can think of
Sure.
yeah. Yeah, I think we have
Any topic, madam has asked any topic, research topic, which you have thought of.
yeah. Sri Lakshmi, do you have a topic? Likhit. We have Dr. Richa.
Yes, ma'am. Ma'am, I
Yeah.
have thought about a topic
Very good.
in microbiology.
Yeah.
It is endemicity of typhoid in a city in Maharashtra.
Okay.
So basically, endemicity will be calculated. Basically, prevalence will be calculated,
Okay. Very good. So you
and
are talking about endemicity. Yes. What are the input
yes.
variables you are looking at? Exposure. So very good. So whenever we are doing a descriptive study, okay, these are all descriptive studies. Whenever we are doing, you're describing very outcome variable is very clear, isn't it? Typhoid.
Yes, ma'am.
Yeah. How are you? We'll start with outcome variable. How are you going to define typhoid in your study?
Ma'am, basically we'll be evaluating the titers in the
Very good.
Vidal test.
So Vidal test. Okay, for all practical purposes, you are taking Vidal test and you are saying fourfold rise in the titers, twofold.
Yes, ma'am.
What, 2 or 4? Again, be very specific.
I'll have to look on that, ma'am.
Okay. So that is exactly, be very clear. From a public health point of view, when we had, I want to little digress from here. I hope all of you remember the COVID pandemic. So when the COVID pandemic stuck, definitions varied from time to time. So clinical definition was, epidemiological definition for COVID was given, wherein they said any individual with history of fever and cough who has been exposed to a person traveling from the endemic area and who also has symptoms is considered as COVID positive or COVID suspect. I hope you're trying to understand what I'm trying to say here. So your variable definition can be different based on feasibility, based on your requirement. From a microbiologist point of view, you are taking bacteriologically or from microbiologically confirmed case. No, you're not actually doing stool culture or anything. You are taking Vidal test, serologically positive case, isn't it? As outcome variable. So in descriptive studies, the input variables, whenever you are studying one particular disease, you are discussing in terms of time, place, and person. So your input variables with respect to persons will be what? The common variable will be age, sex, isn't it? Yeah?
Yes, ma'am.
Yeah. What are the other things? What are the other things which could be the cause from an epidemiological point of view?
Ma'am, ingestion of consumption of contaminated
Very
food.
good. So you can't use the word contaminated food. The probable, most probable, you will define again here. In past 1 month or in past 10 days, have you consumed food from a commercial source, or have you had ice cream? You have to be very clear. Or have you had water from unfiltered source? Whatever. So you will be very clear with regard to your definition of exposure. Especially in your study, what happens is you will just collect data like case sheet. Analysis becomes very difficult. Do not collect data from case sheet. You or case sheet as data. You can collect data from case sheet, but convert it into data. Convert it into variables which are measurable. I hope you remember they vary with people and within the people over period of time, and they are measurable and contextual. They are either exposure or outcome. Yes. So with the measurable, how can you measure exposure? Be very clear. So similarly, you will talk about place, their address, are they hostiles? You will define their place of residence, or you can define based on place of getting water supply, or define place of geographical area or type of family. So these are the variables, input variables you are looking for. From a microbiology point of view, you'll probably have to look at, are you going to do some measurements? Are you going to go, is this going to be a retrospective, or are you going to do a cross-sectional? Are you going to take past data, or at that point in time?
Prospective, ma'am.
Prospective. So you will get a hospital-based study.
Yes, ma'am.
Okay, so you will get samples to your microbiology lab. Whoever it turns out to be positive by Widal, so you will go back to the ward and collect data, isn't it?
Yes, ma'am.
Okay, fine. So you define your time, place, and person variability. You take few variables, very clear-cut variables, and then collect the data. Okay, with regard to the exposure, regard to the place, regard to the personal characteristics. There are so many other things. History of contact. Again, you have to be very clear. Okay, so unnecessarily do not calculate collect too many variables which might be difficult for you. And please do not take case sheet as your pro forma. Richa, some clarity?
Yes, ma'am. Thank you, ma'am.
Yeah. Okay. Anybody else? Anyone doing clinical trial? I'm very interested in finding out if someone is doing a clinical trial. Because here again, exposure and outcome are slightly different when we talk about exposure and outcome, because you are the ones who will be deciding the exposure. You shall divide them. You shall just identify individuals and then divide them into two different exposure groups. You have control over the exposure. Okay. Yeah. So, coming to the way of selection of data, first and foremost, make it feasible. So, with respect to feasibility, I'll just spend half a minute here. There are various ways in which you can make it feasible. First and foremost, try to select data which are the tests which are usually done in your hospitals. Normally, there are certain tests, FBS, PPBS, HbA1c is conducted for most of the patients. So if you take that as a variable, you will not have to spend money. Second thing, if there are certain investigations wherein money is involved, please approach your administration first. Do not go and present to ethical committee saying that I will take permission later, they will do it free for me. No, you have to meet the administrative officers, you have to meet your medical superintendent, the dean, whoever is in charge of your hospital. Ask for conducting these tests at reasonable rate or free of cost for the sake of research. Third thing is there will be funding agencies. So RGHS gives certain grants, ICMRs gives certain grants. There are certain CSRs, there are certain companies which can fund. So especially if you're talking about, again, diabetes mellitus, simple, your GRBS can be done. So you could ask certain companies, especially medicine PGs, you can ask certain companies who will give, they will have certain funds for sponsoring research. They will provide you, you just have to buy the device, they will provide you with the strips for you to do the test. So please find out the feasibility. Do not change your objective. Keep the given objective, keep the given study design, but select the variable and the data for that variable. Variable will be same, the data for that variable based on feasibility. So that is most important factor, especially with regard to dissertation. This is not that, yeah, yes, please. Yeah. Second thing is, it has to be definitely measurable. Don't be very vague. Don't say for some people I will use GRBS wherever feasible. For some people I will do it in the lab. For some people I'll just take clinical criteria. No, that is not acceptable in a research. So what is acceptable? One particular definition you make, how you are going to measure, you will decide, and then you will measure accordingly. And lastly, let it be ethical. Say, for example, surgical or PGs in general medicine or in anesthesiology, you will have to do certain blood tests repeatedly. Just for your study's sake, you can't go on doing those blood tests repeatedly. You can't go on pricking the patient repeatedly, especially in pediatric cases. The ethics committee will definitely not give you permission unless the advantage is much beyond doubt. Otherwise, you might not get permission. So whenever you are planning a study, at the planning stage only, think of implementation. What are all the hurdles you might face? Try to clear those hurdles in the beginning only then present to scientific and ethics committee. Otherwise, your study, you might have prepared the whole protocol and your study might get rejected outrightly. Yeah. So last take-home message, there must be a clear definition that is defined prior and stick to the definition. Don't change because later you got sponsorship. It has to be measurable. Let it be feasible. Only relevant data. What we see is PGs collect a lot of data based on your case sheet. No, you know exposure, outcome variable, and confounders. Confounders based on your scientific knowledge. Ma'am, this ends my brief session, ma'am. I had...
Yes.
Yeah.
Any
other doubts? Any doubts? I'm happy to take doubts. Yeah.
Students, anybody? Participants, any doubts you have?
Subsequently, also, if they have doubts regarding variables, they can ask in your in the WhatsApp group they are in, ma'am. I'll be more than happy to guide them with regard to their variables.
Yes. So I think what they should do is we are sharing the PowerPoint presentations. Yeah. Let them read, let them go through, apply for their research topic. Then they will have doubts.
Dr. Praveen, as an expert, do you have any inputs? Yeah. Praveen is here. I want to take advantage of his
Yes,
presence.
yes.
No,
Yeah.
no, ma'am. I think you have clearly mentioned everything. So I don't think there should be any scope for any doubts anywhere. So if there are any questions, I think as you mentioned, tomorrow also I'll be there every day, so we can
We
just
can. Yeah.
discuss. Yeah.
Yeah.
They should just
Yeah.
know the difference between what is dependent and what is independent variable, and they need to just map their questionnaire based on that. And sometimes there is a tendency among clinical postgraduate students that to take the continuous variables as categorical variables. For example, at the beginning itself, they will categorize HbA1c as when they're collecting, when they're entering their data, they'll be entering it as less than 6.5 as 1, 6.6 to 7.5 as 2, and more than 7.5 as 3, something like that. And similarly to the age also, they will just categorize at the beginning and then they start entering that data. I think they should avoid it. If the data is raw and continuous, they need to just collect it in the same way and enter it in the same way, so that it will be easy for calculating the correlation and other quantitative analysis in future.
Yeah, very apt input. As sir was mentioning, collect the data as it is. You might later categorize it. For the ease, you could always categorize it. Your statistician will do that. But if you're already categorized and then you don't have continuous data, I think it will be a problem later on,
Yeah,
especially when you're
because
talking.
because sometimes what happens is you want to find out whether there is any correlation between BMI and HbA1c. If you have categorized it, the only test that you can do is chi-square test, and you may not get statistical significance. People may ask to give you the correlation. If you have the raw data, the correlation becomes easy. The categorization has got its own limitation. It is as good as you have a kid, and the kid is going to the school, and they categorize grade A, grade B, grade A plus, and all. What is the criteria for A plus? If the student has 95%, 90% could be A plus. What is the criteria for A? 85 to 90, 94. The student who has scored 85 is also given A, and the student who has scored 94 is also given A. So in school it is okay, but in research it is not okay. So that difference of 9 can make a lot of difference in final interpretation of data. So that is the reason, please do not categorize the data at the beginning. Allow it to enter it as it is. Later on, we can see, you can analyze it based on the need for the study.
Very valid point, I think. Yes. Yeah. Right. Any other questions? To participants, you have any questions? Anybody? So I think go back, go through the content, PPTs, and then come back with queries tomorrow. Think of a research topic for your dissertation, and then work on that, and then you will have doubts. Before we wind up on Saturday, I think you should have doubts. Then only we are sure that you have understood something, few things at least you have carried home. So I think, Jayashree, we can conclude here for today. Thank you very much, Jayashree. You made it very simple as always. She has given very lucid presentation and in a very nice way, very simplified manner, whatever it was required. I think that was more than adequate for beginners, for postgraduates. Thank you so much. Thank you, Praveen, for being with us again and adding value to the sessions. So see you all tomorrow, and please work on the assignment which you have posted in the group. Thank you. Thank you, everyone.
Thank you, ma'am.
Thank you. Thank you.
Thank you, ma'am. Thanks a lot. I think it was very, very nice session. So I was not
Yes.
able to join for the initial one. So
Okay.
it got late in my center. So it was a very nice presentation.
Nice session. Yeah. Thank you. Thank you so much. Thanks. Bye.